Hello, everyone. Thank you for having me here today. My name is Nolene and I'm Deputy Midwife Manager at Sims IVF in Clonskee. I've worked in fertility and with Sims Clinic since 2019. To give you a little information about Sims Clinic, it is the oldest fertility clinic in Ireland. We opened in 1997. We have a total of 6 clinics across the country. Our 3 main clinics are divided across Dublin and Cork. 2 are in Dublin, based in Clonskee and Swords, and then 1 there in Mahon Point in Cork. The main clinics are where we carry out procedures such as egg collections, embryo transfers, and intrauterine inseminations. And our 3 satellite clinics, which are located in Carlow, Dundalk, and Limerick, are where we carry out scan and blood appointments. So I'm here to talk to you about all things fertility. So this presentation will include information on what infertility is, the causes of infertility, investigations we conduct in the fertility clinic, treatments we perform, common medications we use, and the impact of fertility problems on a person or couple. So what is infertility? It's defined as not being able to conceive after 1 year of trying naturally if the female is less than 35 years old, and after 6 months of trying to conceive if the female is over 35 years old. Infertility occurs in 5 couples, and it is generally divided into primary and secondary infertility. So according to the World Health Organization, primary infertility is when a pregnancy has never been achieved, and secondary infertility is when at least 1 pregnancy has been achieved before. So there are many different causes of infertility, and sometimes the cause is actually unknown. So there are 3 main factors that lead to a pregnancy. So these are egg quality and quantity, and then kind of the health of the sperm, and then the environment, which involves the uterus. So in terms of the egg, there may be an issue with egg quality or quantity. So we know that egg quality deteriorates with age, and suboptimal egg quality leads basically to difficulties with fertilization of the egg and the ability of the fertilized egg to form into a healthy embryo in pregnancy. Reduced quantity of eggs also occurs as we age. In terms of sperm, then sperm count, motility, or morphology may be abnormal. Sperm can deteriorate due to lifestyle choices such as diet and alcohol intake, and can also be affected by age too. So the third thing is the environment. The environment is the uterus itself. So the uterus accommodates an embryo to implant and a pregnancy to grow. And there are some things in the uterus that might prevent this from happening. So there can be benign growth such as fibroids or polyps, which can basically act as a physical barrier to an embryo implanting. And then things like endometriosis, which can cause inflammation and scar tissue. So these are examples of factors that can contribute to infertility. The other thing to mention is the fallopian tubes. So they both need to be present and they need to be open to ensure that the released egg can travel to meet the sperm, and the embryo can then travel down to the uterus to implant. The fallopian tubes can sometimes be blocked by previous infection, the most common reason being pelvic inflammatory disease, which is a bacterial infection caused by untreated STIs. The bacteria spreads into the fallopian tubes and causes scar tissue in the tubes, which can block them. So we've all heard of the biological clock. Women feel pressure to get pregnant in the peak of their younger years. So this is something we're all aware of and happens to most women. Unfortunately, though, age does matter, as both egg supply and quality deteriorate with age, as we were saying before. So in a physiological way, it's completely out of our control, because this will happen whether we like it or not. But on the other hand, it's something that if we are aware of, we can actually take control of if we take action sooner rather than later. So here's a little pie chart with the breakdown of causes of infertility. So you'll see here it's divided pretty evenly. Infertility is often seen as a woman's problem, but you'll see the percentage of fertility issues for men and women are even, at 30% each. And then 25% of infertility is unknown. So that's where the results of our investigations that we do in a fertility clinic come back as normal. And then some people might think, God, that's a relief. My results are normal. But to be honest, for many patients, it can be really frustrating not to have answers as to why they're not getting pregnant. So then the rest of the chart there, men and women combined will account for 10% of all causes, so combined issues, and then 5% fall under the category of other. So onto some common investigations that we will conduct in Sims Clinic. So the first thing we'll talk about is male investigations. The first investigation we would do on a male patient is semen analysis. So there are 3 different parameters that our embryologists would use when they're analyzing a semen sample. So this is the sperm number, the sperm motility, how they move, and the sperm morphology, how normal they look. So as you'll see there, a semen sample with less than 20 million sperm per milliliter is seen as an oligozoospermic sample or a low sperm count. If there are less than 40% of motile sperm, this is known as stenozoospermia. And if less than 5% of the sperm have a normal morphology, then the sample is seen as teratozoospermic. So it is interesting to note that even a normal sperm sample will have a number of abnormal sperm. So for our female investigations, there are a few more things that we do. We conduct blood tests, antral follicle count scan, which I'll talk about further in a later slide, and anatomical testing. So one of the main blood tests that we will do, and one of the first things our patients will have done, is their AMH levels. So AMH stands for anti-Müllerian hormone. It is secreted by the ovaries, the hormone. And the amount of AMH present in the blood gives us an indication of the numbers of potential eggs that the patient has. It doesn't tell us anything about the quality of those eggs, though, just to note that. Again, as discussed, we know from my previous slides that as a woman gets older, her egg supply and ovarian reserve reduce. So this is reflected in the graph here. You'll see on the horizontal axis that the woman's age is there, and then on the vertical axis is the AMH level. The red area represents a low ovarian reserve, the orange area represents a normal reserve, and the green is a high reserve, which is actually likely reflective of polycystic ovarian syndrome, or PCOS, when the woman has a high AMH level. So these are some of the blood tests that we would carry out as well. We've already spoke about AMH. So we do a panel of bloods called Fertility Profile, and a lot of these are included in it. So the next thing after the AMH is the thyroid function. So thyroid hormones are important in regulating ovulation. So if a thyroid's under or overactive, it can cause disruptions in regular ovulation, thereby affecting chances of conceiving. The full blood count then, or FBC, this is a common blood test that all of us probably have had done at some stage. It checks iron levels, white cells, platelets, and more. But low iron levels can impact ovulation and reduce oxygen levels to the eggs, which can negatively impact egg quality. We also like to know a lady's iron levels and platelet levels before she comes in for an egg collection to make sure there's no risk of bleeding. Then these next 4 hormones, FSH, LH, estrogen, and progesterone, are our menstrual cycle hormones. So these can be checked at various stages in the menstrual cycle to ensure they're at normal levels for that stage of the cycle. Testosterone then, it's a funny one that we check on women, and people are often surprised by this, but we need a normal testosterone level to have good egg quality. So if the level is too high or too low in a woman, the egg quality may be affected. So most commonly, the testosterone level will come back as low, in which case we will prescribe DHEA supplements to bring it into normal range and then increase the quality of the eggs. And something else we prescribe actually is Testogel, for that reason as well. Rubella is another blood test that we'll do, which is to see if the woman is immune to rubella, because contracting rubella or German measles in pregnancy can lead to complications such as deafness in the fetus, heart defects, brain disorders, among other things. So we just want to make sure she's immune before trying to get pregnant. And if she isn't, we'd advise to get an MMR booster and wait 1 month before trying for pregnancy, as the MMR is a live vaccine. Another blood test we'll do is karyotyping. We normally do this for patients who are going to have genetic testing done on their embryos before they implant them. So this karyotyping will tell us if the patient has normal chromosomes. Then on to our AFC scan. So this is an assessment scan that we do to check the AFC, or antral follicle count, in a woman. So we do this at the start of their menstrual cycle when their ovaries are quiet, and we can see how many follicles are actually sitting there in the ovaries. So we'd either see a normal amount of follicles or low or high amount of follicles. So if they're normal, that's great, no problem. But if it's low, it usually would match the AMH level being low as well, in which case further fertility advice is recommended. If the level of, or if the amount of follicles is high in the ovaries, it can be characteristic of PCOS or polycystic ovarian syndrome. And that would usually be seen if there's 12 follicles on each ovary or more. So PCOS can impact fertility as well. So that's something important to note. It'll usually be accompanied by the presence of elevated androgen levels, and often the woman will have irregular periods or no ovulation at all. And as I said, the AMH level often correlates with the antral follicle count. So we'd often find women with a high antral follicle count on scan would also have a high AMH level. A more thorough kind of ultrasound that we do or investigation is the SIS, or saline infusion sonography, or a high COSY scan. So this is a specialized type of ultrasound assessment, which can give us more information about the cavity of the uterus. So what we do is we put saline into the uterus, and you will see in the first image there, this little black area in the middle is where the saline has gone in. So it basically inflates the cavity of the uterus, and we can see if there's any growths there, to like a fibroid or a polyp, those benign growths I talked about earlier, that may need to be removed before trying to get pregnant. And then the other thing we can do here in the second slide is we put in foam. This is a high COSY part of the investigation. So we put foam into the uterus that will then travel through the fallopian tubes. It shows here as bright white. So this is a tube here. So that shows us that the tubes are actually open. And just moving on to the next slide then. So the next thing we're going to talk about is different treatments. So we do many different treatments. So they're all listed there. The first one is ovulation induction. We'd often use medications such as letrozole or Clomid. They're commonly used in these cycles. They are medications that suppress estrogen levels and as a result will increase the output of FSH. Time sexual intercourse is kind of like a step up from ovulation induction. We do use letrozole sometimes, but often in combination with FSH stimulating medications such as Gonal-F, or maybe a combined FSH LH stim medication such as Pergoveris. So the patient will start those medications on day 2 or 3 of their cycle, and then they'd have 1 or 2 scans from day 7 to 12 of their cycle. And when their follicle is grown and their lining looks good for pregnancy, we'll advise them to take a HC3 trigger to induce ovulation. So a HC3 trigger would normally be Ovitrel. Approximately 36 hours after administration, ovulation will occur. And then we tell the patients to have intercourse 24 and 36 hours after Ovitrel administration. The next one then is IUI, or intrauterine insemination. So very similar to a TSI cycle in the types of injections that they take and the types of scans that they have, the amount of scans. The only difference is that after they take their Ovitrel trigger injection, they will be booked into theatre for the sperm to be inseminated into the uterus, directly into the uterus. That happens 36 hours after their trigger injection is administered. Then an IVF ICSI cycle, probably the most common one we do. So IVF stands for in vitro fertilization. ICSI stands for intracytoplasmic sperm injection. So with an IVF cycle, the semen is placed into a petri dish with the eggs so they fertilize themselves. But with an ICSI cycle, the sperm is kind of chosen by the embryologist and injected directly into the egg. And that would be more commonly used if there's a suboptimal sperm sample. So I'll talk a bit more detail about the IVF and ICSI cycles in the next few slides. The other thing that's mentioned there beside the IVF ICSI is PGT. This stands for pre-implantation genetic testing. So this is where a woman will go through all the steps as far as egg collection, and then the eggs are fertilized by the embryologist and they develop into embryos over the next 5 or 6 days. And any good quality embryos will have a biopsy taken from them, which is then sent for genetic testing. The embryos are then frozen in our embryology lab, and the results of the genetic testing take 5 to 6 weeks to come back. And if they're normal, then the woman would go on to have a cycle to implant the normal embryo into the uterus. Egg freezing then, probably one we've all heard of. This is normally done by single female patients to preserve their fertility. And then once the eggs are placed into cryopreservation, they are frozen in time as such. So if at a later stage the woman has met a partner or decided to have a child with donor sperm, and she's at an age where her current eggs have likely declined in quality or quantity, she can decide to thaw these younger eggs from her egg freezing cycle and have them fertilized, and then implant an embryo into the uterus then. So egg freezing cycles pretty much work like the IVF and ICSI cycle, which I'm going to talk about in the next few slides. They involve the same amount of injections and scans. The only difference is that everything stops after egg collection. Instead of going on to implant an embryo, all the eggs are frozen. With donor sperm, I've touched on this a little bit above, but we use this for female patients who've chosen to solo parent, same-sex female couples, or heterosexual couples where the male semen sample is unsuitable or there is no sperm. So patients using donor sperm can undergo an IUI, IVF, or ICSI cycle and PGT cycles. The final one there then is shared motherhood cycle. So this is a lovely option for our same-sex female couples. One partner will go through an IVF cycle and egg collection and create embryos, and then the other partner will have the embryo implanted into the uterus to carry the pregnancy. So this is great for our female couples who want to both play a role in the pregnancy. So now on to more about IVF and ICSI, which is our most common treatment type. It generally has the best success rates and is quite a quick process normally. It can also result in surplus embryos being frozen for future use. And it does have a diagnostic benefit whereby the embryology team can examine the embryos and determine their quality. So there is 5 steps here outlined on the slide for an IVF cycle. So step 1 is the use of stimulating medications, so injections of FSH and LH to grow multiple follicles, which each contain an egg. As the follicles grow, the egg inside it matures, and only mature eggs are able to be fertilized by the lab. So that's why we want a lot of mature eggs. Step 2 then is when their follicles have grown and everything looks good for egg collection, they will take a HCG trigger injection like Ovitrel. So this is given to aid final maturation of the eggs, and then the patient is brought into theatre for an egg collection 36 hours after the trigger injection. And the egg collection takes about 20 to 30 minutes. It's performed under sedation, and the patient can go home 1 to 2 hours later. The patient then starts progesterone medication such as crinone gel, utrogestin, cyclogest, which they take vaginally, or sometimes a Prolutex injection or progesterone and oil injection to prepare the lining for the implantation of the embryo. So that leads us on to step 3, actually, sorry. Step 3 there is a provision of a semen sample for fertilization. That's done on the same day as the egg collection. So step 4 then, the eggs and the sperm are combined to allow fertilization. Then in step 5, the fertilized egg is monitored in the lab for 5 days until it forms into a blastocyst embryo and is placed back into the uterus in theatre 5 days after the egg collection during the embryo transfer procedure. So if there's any surplus embryos that are not used for the embryo transfer, they are frozen and kept in storage for future use. And next then on to our different protocols that we use for these IVF cycles. So there are 3 main ones we use, I guess. They can be seen here as a short protocol, long protocol, and CAP protocol. So the doctor will choose a different protocol based on the patient. It's very individualized. So our short antagonist protocol is the most commonly used, and I'm going to talk about that in more detail in the next slide. A long agonist protocol is less commonly used, but we do use it a fair bit as well. It involves using a downregulation medication such as buserelin, or less commonly Synarel. And we start that medication on day 21 to temporarily shut down the ovaries. So buserelin works on the pituitary gland to stop natural production of FSH, LH, and HCG. So it shuts down those ovaries, and the patient will come in for a scan about 10 to 12 days after starting the buserelin injections. And then she'll start her stimulating FSH, LH meds. So that is how that one works. The CAP protocol then is less commonly used, but this is for patients who have a history of poor response with the other protocols. And it's kind of like a combination of the short and the long protocol. So Just to talk about the short antagonist then, which is the most commonly used protocol, as I was saying in the earlier slide. It normally starts with taking the contraceptive pill for 2 to 3 weeks to then regulate the ovaries and keep them quiet. The patient will then have a baseline scan after stopping the pill and before starting her stim injections. Um, the stim injections I have here Gonal-f and Luverse, but we know Luverse is out of stock until 2025 at least. So at the moment, we're mainly using Gonal-f, Pergoveris, and Recavel as our stimulating injections to grow the follicles. Once they are on those stim injections, they will have another scan about 5 to 6 days later, just to check how she is responding to the meds. And then we'll see when she is to start her antagonist, which is the cetrotide injection. So cetrotide suppresses her LH and therefore prevents premature ovulation. So it keeps control over the cycle. Then the woman will continue to have scans every 2 to 3 days. So another 2 to 4 scans until she's ready for egg collection. The patient will then take her final stim injection, final cetrotide injection before taking her trigger injection. So I think I mentioned previously, the trigger injection gives the eggs a final maturation before egg collection. It's usually Ovitrel, which is a HCG trigger injection. So HCG helps produce LH, which helps in the maturation of the eggs. And buserelin then is another trigger injection we commonly use. This is a GnRH agonist and it stimulates an LH surge as well. Oftentimes our patients actually take the two of them at one time, so they'll both be on our prescriptions. Then another one that our patients may have is Ganassi, which is a HCG trigger also, but we don't use it as commonly as the Ovitrel. So that is how most of our protocols will go. On to the next slide then, there is a little bit about our prescriptions. So all of our prescriptions are created electronically. So we will do a high-tech hub prescription alongside them for medications such as Gonal-f, Pergoveris, Recavel, Cetrotide, and Ovitrel. Usually what we see on the high-tech. The high-tech prescription itself is completely electronic. And what we'd usually do is write the high-tech prescription number onto the remarks on our long prescription so that you can use that to access it on the hub. We email all our prescriptions to pharmacies via health mail address. So these are the main type of fertility medications, which I have touched on already. So we have downregulation meds, stimulating meds, ovulation prevention, progesterone support, and pregnancy support. So downregulation medications is the buserelin, which is a GnRH agonist I spoke about earlier, Synarel, which is the same mechanism as the buserelin. We also have Prostaf, which is a downregulator, and we also use the pill. With the exception of the pill, these medications are mostly seen in long agonist and cap treatment cycles. Then we have our stimulating meds, which, as I was saying, are Gonal-f, Recavel, and Pergoveris usually now. And Luverse, we used to use a lot, but we'll get back into it once it's back in stock. And these are used then to stimulate the ovaries to promote follicle growth. And they're synthetic versions of the hormones mentioned there beside them that a woman naturally produces. So in a natural cycle outside of IVF, you would expect a woman to ovulate 1 egg a month. However, in IVF, by taking these injections, we increase the number of follicles to grow to get as many eggs as possible at the egg collection. Then our next little set of meds here is ovulation prevention meds. So I had mentioned cetrotide previously. This would be our most commonly used ovulation prevention medications. So it blocks the release of LH, luteinizing hormone, which is responsible for ovulation, and therefore that's how it prevents premature ovulation, which keeps all the eggs there for us for egg retrieval. Then our trigger injections, as I said, are Ovitrel, buserelin, and Ganassi. Then progesterone support is another important part of our cycle. So 5 days before an embryo transfer, a woman will start these progesterone medications to prepare her lining for the embryo to implant. So commonly used ones are crinone gel, Protetex, Cyclogest, Utrogestin, and progesterone in oil. The crinone gest, Cyclogest, and Utrogestin are all vaginal medications that they'd normally take morning and evening. The Prolitex is a subcutaneous injection that they usually take once a day. And the progesterone in oil is an IM injection that we don't use as commonly, to be honest. And if we do, it's either once per day or every 2 days. Then we have kind of, I suppose, pregnancy support medications that we use as well on top of everything else. So Clexane or aspirin or blood thinners, and then steroids, which we use to inhibit the immune system. And then we have vitamin D, vitamin B, and folic acid, which all our patients would take. So this is an example of one of our prescriptions. It's a very typical example, actually. Pretty much everything apart from the Luvers is normally on it. So this is how they look. This is what you would get via health mail email when one of our patients has decided to use your pharmacy. Underneath where the folic acid is marked, or at the very bottom, we would normally have a remarks section. And this is where we put in the high-tech hub number for you to be able to access the high-tech prescription. In regards to storing medications, this is a very kind of common question that we're asked. So medications that need to be kept in the fridge are Gonal-f, Pergoveris, Cetrotide, Alvotrel, and Recavel, actually, which isn't in there. And then medications that need kept at room temperature are Luvaris, any of the supplements, and any of the progesterone medications. This is just a little bit more on support medications that I touched on earlier. All of our prescriptions, if you go down to point 4 there, will have antibiotics on them, which is usually actually the doxycycline 100 milligrams once a day for 3 days. This is used prophylactically around the time of egg retrieval to prevent infection. And we'd often have, we'd always have, paracetamol and Solpadol on our prescriptions as well. Paracetamol is just used before the egg collection as extra pain relief to help with the sedation. And then the Solpadol then is if the woman needs it after egg collection. For more pain relief as well. We often sometimes prescribe other medications. So Yasmin as the pill, I talked about that earlier. And then Provera we use if a patient hasn't had a period and is waiting on a bleed to start her cycle, we'd often give her Provera to induce the period. That's a progesterone tablet. Then a lot of our patients are on Eltroxin if they have thyroid issues. And then CoQ10 for egg quality, Dostinex if their prolactin levels are high, DHEA, as I mentioned, and Testagel if their testosterone levels are low, and then metformin as well is often prescribed. These are needles that are required for a lot of our medications. So for Luvaris, when it's back, we would have a 21 gauge needle for mixing, 25 gauge needle for injecting. And Decapeptyl is the same. Buserelin, then we would often ask for either a 0.5 ml or 1 ml insulin syringe to go with this, depending on the dosage of Buserelin that they are going to have. Progesterone in oil, then we use a 21 gauge needle for mixing and a 23 gauge for injecting. It's a slightly thicker substance. One that's not mentioned there is our Prolitex progesterone injections, which would be the same as the Luvers and Decapeptyl. We'd have 21 gauge for mixing and 25 gauge for injecting. So advice we'd always give to patients that might be helpful is just be the healthiest version of yourself. It's better to address any health issues prior to fertility treatment and where possible to remove any factors that would kind of inhibit treatment or pregnancy. So as healthcare professionals and fertility specialists, we recommend no smoking, minimal to no alcohol, usually less than 3 units per week. Reduce your caffeine intake to 200 milligrams per day, which is about 2 coffees per day or maybe 4 cups of tea. Lower, like we don't recommend any high impact exercise during an IVF cycle just because the ovaries get so swollen that there is a risk that they will have a torsion or twist. So we usually tell them just to keep the gentle exercise and stop anything that's high impact, like HIIT classes or boxercise or anything like that. A balanced diet is obviously very important as well. Make sure they have a healthy BMI. Our BMI cutoff is 38 actually, but we do obviously advise them to be within the healthy range. And then we do always ask them to take fertility supplements such as folic acid. And a lot of them will be on just Proceed actually as well. We have counsellor available too, which we would always tell our patients about if they need extra care and someone to talk to. So we have fertility counsellors, 2 of them that work with us in Sims. and that are available to all our patients. And then just general self-care. If it's not a counselor, advising them to do reflexology, acupuncture, meditation, anything like that. So advice for pharmacists then is just a lot of patients would ask about medication side effects. And for example, cetrotide injection, which should be used to prevent ovulation. That would often give a little raised red area on the stomach that will go away after 2 to 4 hours. A lot of them might feel very tired on their medications. As they're on stimulating medications a long time, they can also get very swollen and bloated, which can be quite normal as their ovaries are growing. It's really important to be aware that our patients may feel very overwhelmed or anxious when collecting their meds. A lot of the time, they don't expect to be picking up uh, 2 big bags of medications when they come into you, so it can be very overwhelming for them. And um, I think it can hit them a lot of the time in the pharmacy when they're given those medications, and it's a lot for them to remember as well. So an issue that we will come across sometimes is that some items aren't actually dispensed from the pharmacy. So just ensure all items are dispensed and the correct quantity for the correct duration, because what can happen is that these women will get to the final few days of their treatment cycle and they realize that they have run out of medications or there's something is missing. And I know that these medications need to be ordered in by the pharmacist as well. So it can be a lot of stress on both sides when they don't have all the items from their prescription. We often say to have the medication separated into both fridge and non-fridge items and kind of have them labeled in some way to say which ones are to go in the fridge and which ones are to go in the cupboard. And we are always here at Sims if you contact our nurse line with any queries that you might have on the prescriptions. It's a common thing that we get calls from pharmacies to ask us questions, so it's never any problem. Then just to talk a little bit about the impact of treatment on these patients. So patients will always say to me that they go through all the procedures and the injections and all that, and they kind of get through that, but it's the waiting around for results, waiting to see how their embryos are doing, waiting to see how many eggs they might get, all these things that are really, really hard. And the hardest part is probably waiting for their pregnancy blood test result. So once their intrauterine insemination or the embryo transfer has happened, they have to wait 12 days before they can do a pregnancy blood test and find out if they're pregnant or not. And that's the hardest part of all for them. And all the unexpected things, there's often cycles cancelled and reasons that they can't go ahead and they won't even get to the egg collection stage or won't get to the embryo transfer stage, or ultimately won't get pregnant if they have gone through all those other stages. So this is very, very tough just trying to get from one phase to the next. It's a huge financial impact as well. As we know, IVF, mostly we still have a lot of private IVF cycles, but thankfully the HSE has done something about that now, and we do have public patients coming into, which is great. But for those who are paying privately for their cycles, it is a huge financial cost, and they will be paying thousands to try and have a baby. So that's a huge impact for them. Speaking of that, actually, all of our patients will be told to go on the DPS scheme, so that their prescriptions at least don't cost as much as they could. Then the physical impact of treatment, like as I was saying earlier, the stimulating injections cause all the follicles to grow in the ovaries, and the ovaries get quite swollen. Women can be very, very uncomfortable after they've been on the injections for, even a week to 12 days. They get very uncomfortable, especially by the time they get to their egg collection. Um, some of them find it like hard to walk normally and all that. So it has a huge physical impact in that way. And early pregnancy, if they get to that stage as well, has a huge physical impact too, just to be aware of that. The emotional impact I've spoken about already with all the waiting and the anxiety with all the different stages and results. That kind of links in with the psychological one there. And then socially, I guess it is still an area of taboo. And a lot of women and their partners wouldn't feel comfortable saying that they are going through fertility treatment. Um, it's getting a bit better. People are talking about it more, but definitely a lot of our patients do feel very isolated because the only people they have to talk to are like us in the fertility clinic, or maybe even their pharmacists as you're getting their prescriptions, and they won't have told any of their friends and family. So it can be very, very isolating, and they can feel very, very alone. So I suppose the main thing is that they need a lot of understanding, and sensitivity is required at all times with them. So thank you. That's my whole presentation. If you have any questions, please let me know. No questions? Okay. Thank you so much for listening.